Hello, good evening, good afternoon, good morning to anyone joining. We are being joined today by Dr. Manuel Izquierdo, who is the medical director at IVF Life in Madrid. And we have the pleasure of speaking with him today to answer any of your questions. And he'll be sharing case studies and patients that they've seen who have struggled with implantation failure, repeated miscarriage, and also fertility preservation. So all of your questions answered. We're very lucky to be joined by him today. Hi to those who are joining. He should be joining any minute now. So we'll be covering things like what is repeated implantation failure, what can you do to test for it, what can you do to treat it, what are the treatment options for implantation failure, and also, of course, with miscarriage, the definition of repeated loss or repeated miscarriage, how you test for that, and also what are the recommendations from a specialist to treat loss, next steps. And also we will be talking about preservation, so fertility preservation, who is it best for, when is the best time to do it, and what's the process like. So we're just waiting for Dr. Manuel to join. He should be here any second. I'd love to know where people are joining from today. It's lovely to see you. First live of the year of 2023, so welcome. Let's see if he's here now. Yes. Should be connecting any second. There we go. Hello, hi to those who are joining. Nice to see you today. Welcome to our first live of 2023. We are about to be joined by Dr. Manuel. Here we are. Hello, good afternoon. It's lovely to be speaking with you today. Can you hear me okay? Lovely to meet you. Great. Yeah, absolutely. I have just
Hello,
given
good
a brief
afternoon. Nice to meet
introduction
you.
to what we'll be talking about
Yes, I can
today.
hear you.
But
Can
for
you hear
those who are
me as well?
joining, please could you tell us a bit more about IVF Life and your role?
IVF Life is a group of clinics dealing with fertility treatments here in Spain. We have a location in Manchester in UK as well. And my role in the
Okay.
group is being the medical quality director. So I'm in charge of trying to have quite similar protocols between the clinics and try to integrate the
Fantastic. Well, thank you for your time
scientific
today.
knowledge
You have some case
in our
you're going
daily
to tell us a bit
basis
more about that you've seen
practice.
around implantation failure, repeated miscarriage, and
You're
fertility
welcome.
preservation. So, if we could please start with repeated implantation failure. If anyone watching or listening has any questions, or even watching back, please do DM us or DM the
Yes.
team at IVF Life, who'd be very happy to answer and, consult with you personally for personalized treatment plans. First of all, would you mind explaining what is repeated implantation failure?
Yes, repeated implantation failure is a very common question asked in our daily treatments because some patients are coming after performing some embryo transfers and not succeeding, getting pregnant, and it's a statistical approach. So we consider the statistical question that what is the possibility of a good embryo to implant, and it's about, in the best
Could I just ask
scenario,
you there?
about
You
60
mentioned for
to
a good
70%.
embryo. What grade of
After not
embryo would you
succeeding in the
classify as
first
good?
embryo transfer, there, we classify as a good embryo the embryo being euploid, This means having a normal chromosome account
Okay.
and
And if you were to
coming,
look at
if
grading, would
possible,
that
from
be
a young
1, 2,
woman
3, 4?
under
Would it
37
need to be
mainly.
A, B, would C, in terms of embryo grading, how does that affect implantation failure?
Yes, very, very good question. This is a morphological staging of the embryo. Is how beautiful the embryo is. It's not related with the quality of the embryo. If you put side by side an embryo coming from a woman being 20 years old and an embryo 5AA coming from a woman being 42, you see no differences. But if you know the age of the woman, you can tell the embryo coming from the woman being 20 years old will implant a lot of times more than the embryo coming from the woman being 42 years old. So no differences, no morphological differences. When we are telling about quality, we are telling about some factors inside the embryo, the chromosomal constitution, the mitochondria, some factors affecting the capability of the embryo to divide, to evolve, to grow. And we are very used to tell, oh, very good looking embryos, very good embryos, very good quality embryos, top quality embryos, 5AA, 5AB. This is only a classification. If you have more than one embryo, you can tell the first to be transferred in terms of morphological degree, because at some point, minor differences could give a little bit more implantation rate for this embryo. But the main question is quality inside the embryo is the key question for the embryo to implant. So for considering repeated implantation failure not related with the embryo, you should perform previously at least 3 good quality embryo transfers, because it's when statistically there's less impact coming from the embryo quality and is more on the side of detecting some question that affects the woman, the uterus, the blood, the immunology, the endometrial receptivity, etc. So it's considered that after these embryo transfers being performed not being successful, maybe no more than 5% of the patients are at risk of repeated implantation failure. So it's very common to tell, oh doctor, the embryo didn't implant. So am I the problem? Is a question related with me rejecting the embryo? Is everything okay with me? And maybe you have a lot of chances for having in the next embryo transfer you have a lot of chances of implantation changing nothing, only transferring a new embryo. Not all the good embryos implant, and not failing in the first embryo transfer means that you are suffering a repeated implantation failure. So, because medicine, fertility treatments are experimental sciences, is not working like mathematics or engineering, we need to deal with a statistical approach. So this means like trial and error. And when you have performed some errors, you are at risk of considering, maybe if you don't respond to this antibiotic, I should change the antibiotic. And then if not responding, I will perform an investigation trying to search about the bacteria you're having. But medicine is working in these terms. The first approach is trying to get the most successful treatment, and if failing, you can change your mind and go to search for the not so common questions. This is how it works even for repeated implantation failure. At first time, we are not thinking in
What about if
repeated
you've had one
implantation failure
transfer but
because
two
one
embryos but
only
neither have
embryo
taken?
has failed to implant. Very good question. The first I want you to know is that our recommendation is only transferring one embryo, because transferring two embryos compared with only one embryo increases the chances of implantation only by 10%, and you increase a lot the probability of having twin pregnancy. That is a riskier pregnancy. So transferring two embryos doesn't increase. Maybe if only one embryo, 60 to 70%, with two embryos, you go to 70 to 80% implantation rate. But in case of implantation, 30% of the pregnancies will be twin pregnancies, a riskier pregnancy. So transferring to embryos increases the chances of implantation, but even transferring to embryos and not being successful, it doesn't mean you are suffering repeated implantation
That's
failure.
really useful
You
to
need at
know. So
least
how would you
one
then
more
test
embryo
for it? If
to
you've
be
had
transferred
repeated
for
transfers and they
considering this
have not
situation.
worked, how would you then test for implantation failure, and what would be the suggested treatment plan?
It's very difficult to study this question because we have a little medical evidence. We are performing a lot of tests, but in terms mainly of research. We cannot conclude that most of the tests we perform when we are dealing with repeated implantation failure have the impact of increasing the implantation rate. But if in any way you could help a woman suffering this situation, is the way to go for us trying to search for these conditions. I would tell you about two main groups, or maybe three. The first one we call thrombophilia factors. Thrombophilia factors are very small coagulation factors related with having very small clots in the very small vessels, most of them surrounding the uterine wall and the placenta and making the contact between the embryo and the woman, the uterus. So if these thrombophilia factors are present, sometimes they could impact not allowing the embryo to implant, or even if implanting, making sometimes the probability of the embryo to not have a good implantation and leading to a miscarriage. So if you find these thrombophilia factors, blood test mainly, most of the treatment is based on anticoagulants. We are so used to know that some patients go into fertility treatments are taking heparin, are taking low dose aspirin, or even are trying to decrease the level of homocysteine related with thrombophilia factors. So this is the first group. The second one, the uterine cavity. Sometimes we receive some patients not succeeding after some embryo transfers and being diagnosed of having fibroids in the uterine wall. When you have some abnormality in the cavity, it's normal to think that maybe it could impact embryo implantation. But it's very important to know that even not affecting the cavity and being inside the wall, not entering into the cavity, some fibroids could decrease the implantation rate or could increase miscarriage rate. So thrombophilia, uterine factor, and the last one, the endometrium. Endometrium is the mucosa. The cavity surface of the uterus is covered by some cells that have some transformations and increase during the cycle for getting the best place for the embryo to implant. And most of the times we only need to measure the endometrium by ultrasound scan and few times to have some hormonal factors in the blood for considering a good endometrium. But in case we are facing repeated implantation failure, we start thinking about endometrium as the most important factor. And we are used to perform an endometrial biopsy. We perform, most of the times, it could be performed in the office, not needing any sedation, at very light pain, not suffering a lot of pain, some discomfort, but we have a very small endometrial biopsy that could allow us to study three questions. The first one, window of implantation. Most of the women are having a very large window of implantation. This means the embryo could implant in maybe 1 or even 2 days. The endometrium keeps very well prepared for 1, 2 days for receiving an embryo and implanting. But maybe some women are having a very narrow window of implantation. So it's very important to set the best time for this endometrium to be in the best condition for allowing the embryo to implant. And with the genomic markers in the cells of the endometrium, we are able to set many times, in these cases mainly, the best time to implant the embryo. That sometimes is not the usual one. You need to delay some hours, half a day, the embryo implantation, or you need to advance 1 day, half a day, the embryo transfer. Window of implantation. Second one, bacteria. Today, we are knowing a lot about bacteria in all the places in the body. But today, in our field of fertility treatments, we are very focused to endometrial bacteria. We have good bacteria and we have bad bacteria. The good bacteria are the usual ones, the ones that make the ambient of the endometrium very good for the embryo to implant. And the bad bacteria are the not so usual ones that could be aggressive and could promote a chronic endometritis, an inflammation, an irritation of the endometrium, decreasing the chances of implantation. So, with this endometrial biopsy, we are able to look for the good bacteria and the bad bacteria. If we are having bad bacteria, aggressive bacteria, we can give the patient an antibiotic treatment. And if we are having a decrease in the good bacteria, we give the patient probiotic, antibiotic for the bad, probiotic for increasing the good ones. And the third question we are studying in the endometrium sample is immunological factors. For some reason, immunology is not the same in our body that inside the uterus. Think that when we get pregnant, there is some cells or some genomic antigens coming from not our own body. And in any other situation, like transplantation, heart transplant, liver transplant, sometimes our body is reacting immunologically against this new tissue. But in the case of pregnancy, the immunology is not acting most of the times against the baby, the embryo. But we look for some disbalance in the immunological factors, immunological cells, a lot to be discovered. We are, in my opinion, starting to know how immunology is working in the uterine cavity. And compared with some other colleagues in other clinics, we focus to the study in the endometrium. Some colleagues are focusing in immunological factors in the blood. We think that maybe the best approach is go to the place where the embryo is going to implant and look for these immunological factors at that place. So in summary, when we are facing repeated implantation failure, we need to study thrombophilia factors. We need to study the uterus, abnormalities through ultrasound scan, hysteroscopy, looking with a very small camera inside the cavity, taking into account fibroids, polyps, adhesions, etc., and the endometrial
Brilliant.
sample looking for immunological factors, bacteria, and window of implantation. Depending on the findings, we propose a specific treatment for everyone. Antibiotics, moving the day or the time of embryo transfer, giving immunosuppressors, correcting by surgery fibroids, polyps, or
Thank you.
giving the
Someone has
patient some
asked about
anticoagulants.
taking
These are the
antihistamines.
main
Is that supposed
factors
to be
related with
helpful?
repeated implantation failure. It's a question of research. Maybe I consider that, as I told you, we need a lot of knowledge about immunology, how to treat, maybe antihistaminics, maybe corticosteroids, immunosuppressors, regulators of immunology. I need a lot to know. It's in terms of maybe a
I
lot
think
of
it may have
research,
paused. You
and
should
I
be back in a second. Oh, steroids. I think the connection has gone slightly. Can everyone hear me and see me? Hopefully we will be back on again in a second. This is really, really in-depth and helpful. If anyone has got any questions for IVF Life, for Dr. Manuel, please do DM us, DM them. We can put you in touch and have you connect for a personalised treatment plan. I think that he's had to leave. But the other things that we were going to be talking about were repeated miscarriage and also fertility preservation. So best time to try and do it, what your options are, how many cycles you might be looking at needing, outcomes, success rates, you name it. So all of the above. We'll see whether he joins back now. If not, please do DM us for further information to connect with the team, and we would love to hear from you. So thank you everyone for joining today. It's been great to have heard from Dr. Manuel, and we look forward to the next one.